All right. One more, little less than an hour. We can do it. We got this. So an update for you, or I guess just a reminder for you, no class tomorrow, no class Monday. You can come here, but I won't be here. Feel free to email me if you have questions over the weekend, or if you're stuck or studying, I'm happy to set up a one-on-one, like 30-minute jam session on Teams or Zoom. So reach out if you need anything or if you're getting stuck. On Tuesday, when we meet again, the first hour will be a practice exam. So it'll be 52 questions. You'll have 60 minutes. I'm going to pass it out right at 8, but some of you don't need the full hour. So if you come later, I'll have extra copies for you. It's fine. The following hour will be the review. So if you aren't going to make it right at 8 and you don't want to hear the answers essentially before the review, then don't come until 10. 10 will be when we start lecturing. So not 8 is the exam, 9 is the review of the exam, 10 will be the beginning of the lecture. So if you're kind of keeping in mind your time on Tuesday. Tuesday's content will finish up physiology. So I have some hematopoietic stuff. I have a little bit of lymphatic stuff. So immune system. I have like a brief skin, and then we'll do some cardio pulm during those 2 hours. So that's kind of what we'll spend that 2-hour chunk of time on. And then we'll be moving into biochem and genetics for the most part the rest of next week. Okay. Great. Awesome. All right. I know you're all, I can feel the excitement with that. Okay. I love that. Biochem my background. That's what I love. Okay. Oh, I heard an audible groan. That's fine. Okay. Regulatory substances. So this is an example of when I'm actually like referencing the study guide questions. This is the 2022 study guide I'm referencing. But essentially it's just like, what are the processes of digestion? That's what that's saying. So this is now more focusing on some of the other substances that we didn't cover in the last lecture. Last lecture, we looked at like the big macromolecules and what enzymes are needed to digest each of them, from their macro products that we consume to their micro stuff that we absorb through the intestine. This is more looking at cell types in the stomach primarily, about what are these cells and what are they secreting, because that will also come up on your exam. Remember, gastro is 12%. So gastro and cardio are those two big sections. That's why we spend a little bit more time in physio talking about gastro. So the things that come from the stomach that help regulate digestion. Oh, I'm seeing a chat. Oh, yeah, I get freaks too. Okay, so gastrin comes in your antrum of the stomach. It's secreted by G cells. I think I define what all these things do later. Yeah. Ghrelin is another one that I will mention later. Gastric acid from your parietal cells, intrinsic factor also from parietal cells, pepsin, chief, bicarb, mucosal, and somatostatin from your GI mucosa. So these are your stomach source stuff. I encourage you to know where they come from, the cell type they come from, and a brief action. That's what I would focus on learning for these high yield. Your intestine source stuff, gastrin also, there's G cells in the duodenum. Cholecystokinin, we've already talked about that. It comes from I cells in the duodenum and jejunum, secretin S cells in the duodenum, as well as these others, vasoactive intestinal peptide and bicarb. So again, know where they come from, the cell type, their name, and a brief note about function. We're going to focus on a few of them, but we're not going to go through all. Your pancreas, we've discussed these ones probably the most so far. So your alpha amylase, your lipases, your proteases, and your trypsinogen. You probably could get by just knowing proteases as proteases, but if you wanted to be like extra all-star, learn those specific proteases that I showed you at the beginning of last PowerPoint. Okay. Other places where things come up. So vasoactive intestinal polypeptide also will be released in parasympathetic ganglia in sphincters, as well as the gallbladder. So it has this kind of connection to the nervous system, as well as the gallbladder region. Nitric oxide we'll see sourced in blood. Somatostatins can also come from the D cells in our pancreatic islets, and bicarb from mucosal cells, salivary glands, pancreas, so lots of places. So these are located in multiple locations. And so again, they're often the same substances. We already talked about VIP, but it's located or it's being secreted in a different place. So know what it is, where it's secreted from, and what it does. That would be your important piece. Okay. All right, so looking at a few of them. Bicarb, its main action is neutralizing acid. It's increased with pancreatic and biliary secretion with secretin. And it's often trapped in the mucus that covers the gastric epithelium. So it kind of hangs out in that gastric mucus. So disruption in the mucosa or the epithelium can disrupt bicarb. So if we think about conditions like an ulcer or gastritis of the stomach, the gastric inflammation could disrupt that mucus bilayer or that initial covering of epithelial cells, therefore decreasing the protection that bicarb has to neutralize acid, therefore worsening gastritis. So it can worsen that pathology. We can see the different transportation components of our bicarb here. So this is like lumen of pancreas or intestine. That's where we've located. This is talking specifically about bicarb secretion in the pancreas or the intestine. So we have our capillary here. We have our lumen here, and this is interstitial fluid, and these are our intestinal cells. So bicarb, we essentially are going to have, gosh, where do we want to start? All right, so bicarb being transported into the lumen in exchange with chloride. Chloride is then going to go back down its concentration gradient. So this is kind of a self-fulfilling loop, but this is how bicarb is able to be pulled into the lumen. Bicarb conversion happens thanks to our enzyme carbonic anhydrase. So we have our carbon dioxide plus water, and we get our bicarb. This exchange can occur with our hydrogen ions we take hydrogen ions out in exchange with sodium. We take sodium out in exchange with potassium. So you can see how we can continue to drive this process forward based off of these concentration gradients of ions. So if sodium concentration is off, that could affect bicarb, right? Because if we have a sodium concentration in our blood, that's how these things got here, that is too high or too low, that could change this drive to have sodium being pulled into the cell in exchange for hydrogen ions. We have a buildup of hydrogen ions. It's going to prevent carbonic anhydrase from wanting to convert carbon dioxide to bicarb. So these processes can be affected by the smallest thing like sodium change, which is why we have to know our kidney, because that's where we control our sodium concentration. This is the perfect lead-in. Cholecystokinin, we've talked a little bit about already, CCK. It's going to be increased by fatty acids as well as amino acids. Its action is to increase pancreatic secretions, increase gallbladder contraction, so secretion of bile, and relax the sphincter of Oddi. So it's going to really be involved in doing several different things, but really it's going to help with fat and protein digestion. It's going to act on neuromuscarinic pathways, and it's going to lead our pancreas to secrete its stuff via that smooth muscle contraction. So cholecystokinin, though, can act on multiple different areas, so it is important to note. It's one of our big actors in the digestive system. Gastric acid, we've talked a little bit about this. Action is going to decrease stomach pH, make it more acid. It's increased with histamine or vagal input via acetylcholine or gastrin. So these are things that drive its release. It's decreased with somatostatin, GIP, prostaglandin, and secretin. So these are some of the things that help control it. But keep in mind, so histamine, things that increase our histamine states in our body can increase acid secretion. Histamine we see secreted when allergies often, absolutely, allergies. So in an allergic state, we can see more histamine being secreted or increased. Histamine is going to do what to blood vessels? Vasodilate, so we can move things through better, specifically our immune system cells and blood cells. So we can start to kind of make some of these different connections with areas of the body. I think that's a common question I've seen is histamine's relationship with stomach acid on NPLEX questions. So just recognize those two. Gastrin is an important one to note. It's going to increase our gastric hydrogen ion secretion. So it's going to help make things more acidic. It's going to help with growth of gastric mucosa, and it's going to help with gastric motility. So really focusing on the stomach, gastrin, that makes sense. It's going to be increased when the stomach is distended. So when we eat a meal, if the stomach gets too basic in pH, if we have, if our amino acid concentration is less than our peptide concentration, so if we have too much protein and not enough amino acids, meaning we haven't broke things down effectively, so we need more acid to do so, or vagal stimulation via gastrin-releasing peptide. It's decreased if pH is too low. So if pH does get below 1.5, it will stop secreting gastrin. So it won't continue to make our pH lower and lower and lower. It does have that negative feedback component. You should note that it will be increased gastrin with chronic PPI use, because if you constantly block that peptide pathway or that proton pathway, you take those away, the body is like been trying to override its normal physiology for so long. You remove PPIs and you have this influx now of gastrin that's been trying to override its normal feedback loop. So that's why people can have an adverse reaction when stopping PPIs of really significant reflux. So you always want to taper. We can talk about that another time. You won't have farm questions on this test. Chronic atrophic gastritis and Zollinger-Ellison syndrome or gastrinomas. Those are things that can increase the secretion of gastrin in a pathologic way.
Most of the actions are on the stomach. Why it's secreted by the duodenum?
Yeah, so it's secreted by, if most of the actions are on the stomach, why is it secreted by the duodenum? Where is it being secreted? That's the question. Is it secreted as a hormone? Is it secreted as a secretion? Hormone. It's secreted as a hormone. So it's being secreted into circulation, and then it's affecting the stomach and everywhere. But its action and specificity of seat is the stomach. Yeah, excellent question. And that's where these things start to get, that's why I say know if they're hormones or secretions, right? They're all being secreted, but are they being secreted into the lumen or into the blood? Blood will be hormone, lumen will be secretion or part of the gastric juices. You'll sometimes hear that being said casually. I think that's how I said it in gastro this year, as I said, it's in the gastric juice. Pretty sure that's what I used to try to not use the word secretion since everything's technically being secreted. Okay. Ghrelin, leptin and ghrelin helping with your appetite control and your hunger signaling. So ghrelin is going to help ideally increase your appetite. It's increased when you're fasting. It's decreased when you're fed. Okay, so that's how you remember your ghrelin. It will be increased pathologically with Prader-Willi syndrome. So then you are going to have an inappropriate appetite for where you're at in your fasting versus fed state. I say inappropriate in response to what your body currently needs biochemically. It'll also be decreased by gastric bypass surgery, ideally. These don't always work perfectly. So you learn the perfect way that you need to learn it for NPLEX, but know that realistically, these hormones are affected by a lot of stuff. So this doesn't always necessarily mean hunger. This always doesn't mean satiety. Leptin. Glucose-dependent insulin-trophic peptide. It's exocrine in action and endocrine in action. So this is a hormone and a secretion. It does both. As an exocrine secretion, it's going to decrease gastric hydrogen ion secretion locally. As an endocrine hormone, it's going to increase insulin release. So it's going to be released into blood and into the local lumen. It's increased by fatty acids, amino acids, and glucose. And it also can be called gastric inhibitory peptide. Intrinsic factor is the one that probably is the most important to know. If you only want to learn one today, learn intrinsic factor. It's because it's involved in vitamin B12 uptake. It's a vitamin B12 binding protein. It's the way that we take a vitamin B12 up in the terminal ileum. And that's where vitamin B12 is primarily absorbed. It will be increased with histamine. It will be increased with vagal input via ACH and gastrin. So similarly to hydrochloric acid, actually. It's decreased with somatostatin, GIP, prostaglandin, and secretin. It's in the autoimmune destruction of parietal cells, you can get chronic gastritis and pernicious anemia. So if your parietal cells, that's what secretes intrinsic factor. If they're destroyed, if they're damaged, if they're attacked, and you cannot secrete intrinsic factor, you can get chronic gastritis, pernicious anemia, and actually death. It is the one gastric secretion that you cannot live without. You have to have intrinsic factor or be able to replace it because you have to have B12 to live. Pretty cool. All right. Let's see. How many more do I have? Oh, we're almost there. Okay, we're fine. Motilin helps with migrating motor complexes. It's going to be in our fasting state released, and it's going to help with intestinal peristalsis. I would say this one's lower on my list of things for you to know. Nitric oxide, again, this would be like second tier of things to learn for the digestive tract, but it will increase smooth muscle relaxation and specifically the lower esophageal sphincter. Pepsin, this one we already discussed, protein digestion. Secretin, we already discussed. Somatostatin, we've discussed, but it is an important one to know. These three I would make sure you know, you understand. And VIP, we didn't talk about this one. So VIP, vasoactive intestinal polypeptide, your increase is going to be intestinal water and electrolyte secretion. It's going to help with relaxing, and also it's going to increase intestinal water and electrolyte secretion and relax your smooth muscles and your sphincters. It's increased with distension or vagal input, parasympathetic input. It's decreased by your stress state. So we can see this is the major, I would say, secretion that is affected when we are in a sympathetic dominant state. It's going to affect our ability to move things through our digestive tract in a healthy way. So it's going to affect gastric motility or gut motility. A VIPoma is there's a non-alpha and non-beta islet cell pancreatic tumor, which secretes VIP. In this syndrome, obviously, you're going to have water and electrolytes secreting more than you would want, and your motility would move a lot quicker than you'd want. So that would lead to diarrhea. And it can lead to essentially what we would call WHDA syndrome, watery diarrhea, hypokalemia, and achlorhydria. Things are moving too fast and too much is escaping. All right, good. I know that was a clickety split quick. I just wanted to get to some kidney today before we go. Yes. I don't, discovered and named? I don't. It's on the list. I don't know the first one. Secretin, awesome. First hormone, let me get, so first hormone to be discovered and named. Awesome. That's great. So secretin, first hormone to be discovered and named. I love that. It makes sense. It's like the big one of all. It's like everything. It's secreting. Yeah, absolutely. Well, we'll join a medical trivia team. You should be on the NMSA Cup team. I don't know if that's still happening. Yeah. All right. Awesome. I love that. I love medical trivia facts. I was on their cup team back in the day. We didn't win, but we won some stuff, but we didn't win like the trophy or whatever. We weren't like awful, but we weren't great. Okay. Nephron molecular transport. Are you surprised I was on the cup team? I mean, come on. Yeah. Okay. So our nephron, the kidney. Don't be afraid of the kidney. The kidney is fine. You're going to be fine on your kidney questions. I trust me. Okay. So we're going to go through the nephron. I'm going to focus on our different areas of our tubules, and we're going to talk about some of the where reabsorption of stuff happens. And that's probably what we'll get to today. So we'll see how far we go. So in our tubules, we have our proximal convoluted tubule, we have our loop of Henle, and we have our distal convoluted tubule, and then our collecting duct. So that's kind of what we're going to pass through. The proximal convoluted tubule, you can technically break it into early and late, but we're just going to talk about it as the PCT, proximal convoluted tubule as a whole. It's brush border, so it does have an actual little like brush border component that reabsorbs all glucose and all amino acids. All of it reabsorbs here. Reabsorbs means what? Back to the blood. Yes. From the lumen of these tubes back to the blood. So when I say reabsorbs every time, I mean from the lumen to the blood. If I say secretes, I mean from the blood to the lumen. So this is where all reabsorption of glucose and all reabsorption of amino acids takes place. When would that not occur? When would we see glucose still left in the lumen? Hyperglycemia. If we have too much glucose in the blood and we've already essentially occupied all of our glucose transporters, if those all have glucose in them being transported, there's going to be glucose left over, and that's how we get glucosuria. So that's how that happens but in a normal state, we're talking normal physiology, all glucose, all amino acids get reabsorbed here, okay? This is also where we reabsorb the majority of bicarb, sodium, chloride, potassium, water, uric acid, and phosphorus. So when in doubt, things are getting reabsorbed the most in the proximal convoluted tubule. Okay. Of note here, there is a sodium phosphorus co-transporter in this. It's not represented in this image, but there is a parathyroid, or there is a sodium phosphorus co-transporter that's located in the proximal convoluted tubule. Parathyroid hormone inhibits that co-transport. So this is where we could see some endocrine relationship affecting some of our reabsorption. We'll see some other hormones that come in and inhibit and mess up our absorption as well in other areas. Now the descending loop. So we have our loop of Henle. We have our thin descending loop. We have our thin ascending loop, and we have our thick ascending loop of Henle. So our thin descending loop of Henle, we have passive reabsorption of water. We are not doing anything to sodium. And so this is making our urine hypertonic. It's making it concentrated. We are bringing back water into the blood, but we are leaving behind whatever sodium was left over after the PCT. So this gives us concentrated urine, the thin descending loop of Henle. Passive water, no sodium. The thick ascending loop of Henle is where we are able to reabsorb sodium again, potassium, and chloride. It's going to indirectly have some magnesium and calcium absorption paracellularly between cells. When I say paracellularly, I mean between. Transcellularly means through the cell. You'll also have this section will be impermeable to water, and the urine will become then less concentrated. So if we think about this, we absorb everything we can in the PCT because we want it back into the blood. Whatever's left, we keep it in here except for water. We take water back during the thin descending. Then we kind of recalibrate that concentration in the thick ascending. So we're absorbing in some of the other ions, and the urine becomes less concentrated because we've taken out some ions. And then we're left with the DCT, the distal convoluted tubule, where any other sodium that we can reabsorb plus chloride, we're going to reabsorb via a co-transporter. And in this section, it cannot absorb water. So no water can be absorbed during the DCT. This will make our urine fully dilute, hypotonic, because we're leaving the water in the lumen and we're taking out solutes. Okay. At this stage, our parathyroid hormone also can affect this DCT. It'll actually increase calcium reabsorption via a calcium sodium exchanger. We don't have that picture on here, so I apologize. I don't have that transporter on here. That's why I wrote it. Then we get to our collecting tubule or collecting duct. This is where we have a tiny little bit of sodium in exchange for potassium and hydrogen. And aldosterone is our main regulator of this section. This is also where antidiuretic hormone is going to take effect by inserting more aquaporin water channel on our apical side, the urine side, to increase water reabsorption as well as urea reabsorption will take place here as well. And these AQPs are the example of the aquaporins. Aquaporins are essentially taking in water from the lumen into the cell, and then from the cell into the blood. Those are the aquaporin channels. So that's what antidiuretic hormone is acting on the collecting tubule or collecting duct. It's causing more increased reabsorption of water. A little bit of sodium is getting reabsorbed here in exchange for potassium and hydrogen, and aldosterone regulates that process here at the collecting tubule and duct as well. If you know that, you will be fine for almost all of your kidney reabsorption questions. Okay, so that's what I would focus on. Now, could there be some that ask you about specific co-transporters? Sure, there can. I'll post a more in-depth lecture about the specific co-transporters. So if you want to go into them, go for it. But for this, for now, 2 weeks out, kind of before your exam, 3 weeks out before your exam, I think we're actually 2.5 weeks from right now. I would focus on like make sure you have this high yield, and then if kidney's easy, then go into co-transports, you know, all those pieces of the puzzle. Any questions on this one? before I move on to the RAS system. Okay, renin, angiotensin, aldosterone. What do? Well, it regulates blood pressure. Okay, this is probably, I have a couple different overview slides, and then I get into the specifics of the different components, but we'll look at the overview slides first. I think they're just easier. So your liver is producing angiotensinogen. Your kidney produces renin. Okay, so that's the first differentiation. Angiotensinogen in the presence of renin becomes angiotensin 1. Angiotensin 1 in the presence of ACE, our angiotensin converting enzyme, becomes angiotensin 2. ACE is secreted or essentially located in your lungs and your kidney. It's on the surface of pulmonary and renal endothelium. So that's where it's located. So you have ACE enzyme in both those spaces, which is why we have ACE inhibitors. As a side effect, you can get a dry cough that is affecting your lungs. Angiotensin 2 is then going to activate. Angiotensin 2 is really the active thing here. It's going to cause the action on all the stuff. It's going to increase sympathetic activity. It's going to increase tubular sodium chloride reabsorption in exchange for potassium. So it's going to be potassium wasting. It's also going to keep water because water follows sodium. It's going to affect the adrenal gland cortex by increasing aldosterone secretion. So in which layer of the adrenal gland is aldosterone secreted? Glomerulosa, right? GFR, salt, sweet, sex. So you remember it, G, glomerulosa, aldosterone, salt. Never forget it. Okay, last year I kept forgetting it like every moment, so it's in my brain now. Arterial vasoconstriction will increase your blood pressure. And then pituitary gland, posterior lobe, you're gonna have ADH secretion, which is then going to focus on more water reabsorption in the collecting duct. Why? What is this whole process trying to correct? Low blood pressure, right? Hypotension. So it's going to be if the body senses hypotension or low blood volume, that's what activates the RAS system. We try to block it to treat hypertension, but the body uses this system to manage hypotension. So I think that's a key piece for us to keep in mind. Okay, this is just another way of looking at it and to see kind of what is happening with blood volume and blood pressure. This is really the same idea, same system, just more focused on what's going on with blood pressure here. So looking at renin, it's secreted by our juxtaglomerular cells, or JG cells. You can see this picture is kind of blurry, so I apologize. I don't know if you can see juxtaglomerular apparatus. Okay, these orange cells are the JG cells that are secreting renin. So located here. This is your glomerulus. This is the filtrate that's coming out. These are the blood vessels coming in. So this is where your tubules would be on this side over here. Glomerulus, blood going in, blood going out. And then that's where your JG cells are located. You'll see increased secretion of renin with decreased renal perfusion pressure. So there's baroreceptors here that are assessing how much flow is going through your kidney, your nephron. That's detected at the afferent arteriole. That's why these JG cells are located close by. You'll see it'll increase renal sympathetic disorder. I don't understand. Discharge, maybe is what I meant. Increased renal sympathetic discharge, which is a beta-1 effect. I believe that's what I meant to say, but it's not disorder. And it'll decrease, it's decreased sodium chloride delivery to the macula densa cells. So we will see here, these JG cells, their main job is to secrete renin in response to the change in pressure or volume. You think of them as hanging out or listening to baroreceptors. ACE inhibitor catalyzes conversion of angiotensin 1 to 2. It's located in multiple tissues, mainly lung and kidney. The conversion occurs the most in the lung, ironically, and it's provided by vascular endothelial cells in the lung, but it will occur in both places. Here's an example of an angiotensin 2. So once we get the conversion of angiotensin 2, We will see all of the things that it does. Its really goal is to maintain blood pressure and volume. It will affect baroreceptors and it will limit reflex bradycardia, meaning low pulse in response to low blood volume. So try to increase or keep that pulse rate up to maintain adequate perfusion when you have a low blood pressure that it's correcting. So all these things that it's doing are listed here. The other components that are important to know that we haven't discussed is ANP and BNP, which is atrial and brain natriuretic peptide. These are released from the atria, the ANP, and ventricles, BNP. They're released due to increased volume to inhibit RAA. So these would be the controllers of the RAS system. They essentially will allow for a relaxation of vascular smooth muscle via cyclic GMP, so second messenger system. And they'll lead to increased GFR, so increased filtration rate and decreased renin production. It will dilate your afferent arteriole, so the blood vessel going into the kidney. That's how it's going to allow for decreased renin. So the kidney will then say, oh, I don't have a change in my arteriole that I need to pay attention to. It's now dilated. My filtration rate's increased. I can relax and stop secreting so much renin. We check BNP in congestive heart failure. So if it increases, we can see this increase when we have a CHF exacerbation. ADH vasopressin we've talked about, so I'm not going to necessarily spend a lot of time here. We've already discussed it a little bit. And same as aldosterone. Yes, please. Yes.
About what the difference is. Doesn't it like also kind of regulate blood pressure?
Yes.
What is it sensing different as compared to renin?
Yeah, that's great. So renin secreted by the kidney in response to low blood volume or low blood pressure directly at the kidney itself. ADH secreted by the posterior pituitary in response to a pressure change located, a baroreceptor change located up at the posterior pituitary and hypothalamus. And also in response to osmoreceptors measuring sodium concentration. So ADH, antidiuretic hormone, is paying more attention to osmolarity than pressure, so the concentration of salt in the blood, versus renin's paying more attention to the actual pressure or blood volume itself. Based, yes, correct. Correct. So renin, think about more pressure and volume, and then ADH, think about more serum osmolarity, so sodium. It can also respond to low blood volume states as well, though. So it does have a baroreceptor function, but it has an osmoreceptor function too. But
or kind of secondarily.
Secondarily, yes, secondarily, but not primarily. Yes, good question. Absolutely. The goal of vasopressin is to also increase water. Vasopressin or ADH is released in response to angiotensin II. So if you have the renin system activated, one of renin's jobs is to get to angiotensin II, which will also secrete ADH. So angiotensin II can stimulate directly ADH secretion. So the RAS system can tell ADH to be secreted. And then ADH, renin is just telling the system to start. ADH is actually the one that's responding to the collecting ducts and helping water become reabsorbed. So you could almost think as like renin as the commander in chief telling for like a bad thing, but like telling people what to do or giving the top of the hierarchy. And then ADH is actually the person going out and completing the task. And angiotensin II is like the middleman communicating between the two of them. Is that better? Yeah. Okay. I saw a hand in the back. Did I answer it or did I make it worse? So vagus nerve, think more in response to cardiac contractility or vasculature systemically, not necessarily focus on blood volume quite as much. More cardiac output and stroke volume and those pieces, but more cardiac specific. There is effects elsewhere with the vagus nerve, but That's how I would kind of separate the two. Question. Awesome. Hand or stretch? Stretch. Okay. No, you're good. Awesome. All right. I have a couple slides on metabolic acidosis and alkalosis. So I want you just like know that they exist here. We're going to talk about them more in the path section. So I encourage you to review these now. And then when we talk pathology, then we can have a discussion because I want to talk about them in conversation with path instead of just separate. And same when it comes to nephrotic and nephritic. So these are some path slides, kind of preview path slides that we'll get to when we discuss pathology next week. But I just wanted to leave you here with them because these really go well with our kidney discussion. All right, we have like 4 minutes. Any questions for me? Yes.
Like is the aldosterone at the end of the renin and your everything?
Yes.
The aldosterone, does that talk to ADH too?
They all talk together. So I think this is probably the best version to look at it. So aldosterone and ADH are both responses that happen from angiotensin II. Aldosterone is focusing on the collecting tubules and ducts on reabsorbing sodium. ADH is focusing on the collecting tubules and ducts on putting aquaporins to reabsorb more water. Both then, if we reabsorb more sodium, we're going to pull more water. And if we reabsorb more water, both those things are going to increase blood volume, increase blood pressure. So both of them have different mechanisms of action, but they're acting in the same way on the same actually tissue even to increase blood pressure and blood volume. But they're released in response to angiotensin II.
The aldosterone is going to take care of the salt. The ADH is going to take care of the water.
Correct.
Acting in the same issue.
Collecting tubule. Yep. And really, aldosterone will pull in some water as well because we're increasing salt. The real key difference is ADH is actually inserting aquaporins, so essentially giving more receptors for water to actually bind to and be pulled across. So the concentration gradient could be formed by aldosterone pulling more sodium, and then the actual availability of receptors is increased thanks to ADH, which allows more like water receptors, essentially aquaporins, to be present in the lumen, so more water can be bound and transported. Like you'll just have aldosterone being triggered and not ADH? You could see them working more independently, especially if you see like pathways of deficiencies in enzymes like we saw in the adrenal gland. So then you could potentially see like blockages or issues with one, but not the other. Or same thing if you had a pituitary or a hypothalamus lesion that was affecting your pituitary gland or your hypothalamus from secreting or creating ADH, you could potentially see aldosterone working fine, but ADH having a hard time working. Because ADH is from the pituitary, like brain, hypothalamus, pituitary, versus aldosterone is your adrenal glands. SIADH, syndrome of inappropriate SIADH. Yeah.
So, and that doesn't have anything to do with the aldosterone?
No. So you still have some function because you still have aldosterone, but ADH is malfunctioning.
Okay.
Yeah.
Thank you.
Yeah. This is good stuff. Anything else? Online, I saw a hand or a question. No, thank you. Awesome. Thank you all. I appreciate it. It's been a great first week. I'll continue to upload some stuff over the weekend, and then you'll have your next practice exam on Monday or Tuesday. Don't come Monday. Bye.